Welcome, everybody. So this is the first of our outside speakers for this year's Conversations in Health, Global to Local. We have a rock star speaker to kick us off, so we are in very good shape. As you all know, Dr. Michelle Roett has joined us here, and we're going to hear a lot more from her as the night goes on. So let me, but as is our tradition in this, so just to remind everybody of our format, we will, Dr. Roett and I will spend some time talking about her background and her history. We'll then turn to each of you. We'll start with the three students who did the briefing emails, and then we'll open it up to the full class. And if there is time, we'll open it up to questions from the people who are on Zoom. So why don't we, as we always do, we'd like to start at the beginning.
Okay.
So why don't you tell us a little bit about where you grew up and a little bit about your life before you came to college, because so many of the people here are either in college or just soon thereafter thinking about their careers. But why don't we start at the beginning, if you wouldn't mind, and kind of give us a kickoff.
I grew up in Barbados. That's where I was born and raised. And so I knew I wanted to do medicine from a very early age. I didn't have any health care or doctors in my family. But my mom was a social worker and my dad was a teacher, and they were extremely diligent at teaching me about what my role was in my community and what I could give. My mom as a social worker was completely accessible to everybody, and we had multiple cases that happened at our dining table, and I was always by her side as a child. When in Barbados, orphanages are called children's homes, and my brother and I have lots of stories about our friends that we made in the children's homes that she worked in and that she spent time in. And over the years, all of her clients really absorbed and welcomed us and loved us the way how she gave of herself to them. And she loved working with women and children. That was her passion. She passed away a few years ago. And my dad was a teacher, and he was also a pioneer. He started a school for people who weren't able to finish high school in the 70s. And so his legacy for my brother and I was that we needed to figure out how we were going to give of ourselves so that other people could be lifted up. And at the time, I thought for sure that I was going to be a psychiatrist, and that's how I was going to be lifting other people up. Right. I loved my mother's lessons of counseling and listening to people and trying to help them to cope and give strategies and working with people where they're, meeting them where they are. So I completely thought that's what I was going to do. I had some shadowing experiences in hospitals and in family medicine spaces before I got to undergrad. And then I got to Johns Hopkins for undergrad. There's a long story to that too, but I won't bore you with that. But my family has lots of roots in New York City, and that's where we spent a lot of our summers. We were really fortunate to be able to go. My grandmother, my great-grandmother moved there many decades before I was born. And so just going there was a tradition, and the expectation was that I would just go there when I could, but that I would go to school in the Caribbean. So it was a complete surprise to my entire family when I applied to go to school in the United States. They thought for sure I was not ever going to leave. And so I was like, surprise, I got into Howard and Hopkins and all these other places, and my dad was so not happy about it.
He didn't think this was a good idea.
Well, not only that, we could not afford it, right. and silly me hadn't thought about how we were going to pay for college. But it fell into place in that I got scholarships, I got I got student loans, I got funding from different sources in Barbados, and I was able to come to Baltimore as my first time away from home, and I really enjoyed it tremendously. Hopkins, I learned how to be who I am today. Okay. Definitely learned that psychiatry was probably not the field for me, but not because I didn't like psychiatry. I love it very much, and I work very closely with behavioral health professionals. But I found that family medicine was my calling while I was there. I shadowed psychiatrists, I shadowed psychologists, social workers, primary care docs, And then it wasn't until I got to Georgetown that I realized, based on the role models that I had here on campus, that, oh, I made the right choice. It is family medicine for me. They were doing everything I wanted to do. And I always tell students when I talk to some of our high school students that we work with over the summer that I had a pivotal experience as a medical student. In my first year or second year, I met with the chair of family medicine, which is my job now. And I sat in the chair with him. He was an older white male. I wasn't sure what to expect. It was our first meeting. I'd never spoken to him. And he said, tell me a little bit about what you're going to do in the next 5 to 10 years. What do you want to be? Where are you going to be? What are you going to be doing? And no one had asked me a question like that before. And it forced me to think about my career and what I wanted to be doing. And in that moment, it was just verbal diarrhea. I just said everything that was on my mind. I just said, I want to do research. I want to do community partnerships. I want to be out in the community doing community engagement and service. I want to be doing inpatient, outpatient. I want to be delivering babies. I want to be doing all, it was such a long list of things. And he was like, hold up. You're like, how are you going to do all those things? And I said, well, I want your job. How about your job? I could do all those things. And he said, that's probably true. I have done all those things. And I knew all of the family docs that I'd worked with and volunteered with and spent time with had done those similar kinds of careers. So he really took me under his wing as his mentee from then on. And I stayed at Georgetown for my family medicine residency training. I did my community health fellowship with Georgetown as well. And then I stayed on as faculty. And
before we get too far into your being a doctor, but back to, because so many people, as you heard, we have a number of undergrads here, including a couple of graduate students who are thinking about medical school. What did you study at Hopkins? Because you obviously were thinking about what you wanted to do to be a doctor. So did you knew from when you were young and going to Hopkins didn't change your mind on wanting to be a doctor?
No, not a bit. I was pre-med. At the time, there was no pre-med major there, so I was a biology major and a psychology major by the end. At Hopkins, there was a lot of good opportunity in the School of Public Health as well. So many of us who were pre-med at the time, I think this is still true, did lots of our work and volunteerism within the School of Public Health. It really felt like that was the place that I met people who were like-minded, who really were interested in community health, primary care, service, and that is the place where I felt like I found my calling. I found the Association of Public Health. I really felt like I belonged there. Made me consider for a moment the research path.
Right, because that is, well, at Hopkins it's not uncommon, right?
Exactly, but in the end, it was great preparation. Some of the people I worked with really made their mark on me, and I still do, grants and research and writing the same that I did back then. I still use the principles I learned, and some of the people are still in my working sphere that I worked with in the School of Public Health. So I think that's what made me feel, even though Hopkins doesn't have a family medicine department and doesn't have people working in this family medicine space, it still brought me to medicine and family medicine.
So you felt, certainly by the time you got to medical school, you felt okay to tell the chair that you were thinking about his job, and he was open to that. But so then, as you thought about your time, your medical career and your residency, it just affirmed that family medicine was the right path. When did you? So how did that play out? You were here in DC, or did you do your residency elsewhere?
I did my residency at Georgetown as well. Yes. And to be honest, my mom has always been the one who says you need to be the leader and not the follower. She used to have a saying, you don't want to follow your friends off the cliff. You need to be accountable for the decisions that you make, and you need to be able to take responsibility if something happens. And I totally ignored that throughout my childhood. But I recognized the value of that, as soon as I left home, and understood, why she always said that. And it's true. My brother and I are typically the ones who will volunteer to lead something or to solve something or, to be the ones in charge. And, if you see something that isn't working or isn't going well, why not solve it? Be the change, understand what your role is. And so she taught me that well. So I'm often looking for leadership roles. And as a medical student, as a first year, I was looking around and thinking, I'm not seeing people that look like me. You know, there's not many women in leadership roles in this institution. At the time, there was one woman chair in the School of Medicine, and I became the second woman chair. So it really still hasn't been that many. There's a few more after me. So I knew that, you know, in looking at the role models at Georgetown, that I wanted to be a part of that group. And I wanted to change how it looked because I wanted people to see more of what there was to offer. Mm-hmm.
So let's jump into what you, because, I mean, just for everybody here, Dr. Roett's been a leader in changing not only how we look to the world, how the faculty and the administration, but also how we think about education here. So tell me, after you finished, you went on faculty here, and how long, and why don't you tell us a little bit about your practice,
Sure.
and then I'd like to really look at what you've done to change Georgetown. But let's start with the practice, because I think that informs what you did here.
For sure. I was a fellow first, the year before I became full-time faculty. And as a fellow, you get to do a little bit of everything. You get to do the academics, the research, the clinical part, the service, and it really showed me the type of role that I wanted to have. I was a faculty member who was placed at Unity Healthcare in DC, in Southeast DC. And, you know, understandably in that year, I really felt like, okay, this is it. I found it, you know, this is what I want to do. And throughout that year, I had such a fantastic experience just learning about, you know, how I could play a role in the lives of my patients and how I could be that person who they lean and depend on as their primary care doc. As a family medicine resident, you are the continuity provider for all of your patients. It's not like other specialties where you shadow someone else and you see their patients. Every patient that you see is your patient and you're responsible for them. You know, you've got supervision, of course, but you're responsible. So as a fellow, I really understood, you know, this is what I'd like in my own practice. So I delivered babies for 15 years. I did inpatient, outpatient, academic medicine, the research portion of the role. I saw geriatric patients. I did a mini fellowship too in geriatrics. I took over many of the geriatric patients from a geriatrician that used to work in our office. So I see the gamut. I see the newborn babies. Most of the babies I delivered are all grown up now, but being able to watch them grow up is such a privilege. And then to be with a mom during a pregnancy, there's nothing that replaces that. It's so exciting to watch someone go through the stages of pregnancy and delivery, be in the delivery room, deliver the baby. There's just nothing like that. Knowing the person, it's very different if you're on shift and somebody comes in to deliver, you never met her. Right. But if you're taking care of this person from the moment the pregnancy was diagnosed, it is a journey, emotional journey you go through together. So I really felt like I wanted to keep that. I wanted to continue doing it. And so delivering babies became a big part of what I was doing, and then teaching others how to do that. Yeah.
Mm-hmm. Well, and did you do most of the, I know your fellowship you worked at the Unity Health Clinic, but did you stay working in the clinic in Southeast as part of your but because you came to come here, right?
I came here, yes. So the clinic in family medicine, we have three. We have one that's our residency practice that was in the Fort Lincoln neighborhood in Northeast DC for many years and moved to Prince George's County about 25 years ago. We have our faculty practice that's on Massachusetts Avenue, so mostly caters to people who live in the Georgetown community. And then we have Hoya Clinic, which is in Southeast DC at our Triumph Homeless Shelter. So all of our clinics I oversee as the clinical chief. We have another clinic we're about to open in Clinton. So I think all of the different clinics give you a different view of what patient care means at Georgetown and beyond. So the key is that what happens here is not typically what you'll be seeing as you take care of patients. We have a presentation that we do to students that we gave today that shows maybe about 1 in every 1,000 interactions that happens for clinical care happens in an academic hospital. So maybe about 200 or 300 of those might happen in an emergency room, might happen in in an outpatient acute setting that you get transferred to an emergency room. So in general, maybe that 1 out of 1,000, that really is a very small percentage of care that happens. So thinking about that other 999, a lot of that happens in the ambulatory setting, particularly with primary care, because we do the most continuity visits with our patients. But, you know, in subspecialties, you still have outpatient clinics too. So there's lots of representation of that. And I really felt like I wanted to make a difference in that space, both in the community engagement that I was doing, but also in my clinical practice. I chair our quality and safety committee. I do a lot of work in eliminating disparities in care. And I wanted to see, you know, how could I do that from the inside and from a leadership role? And, you know, if you've got access to the data, can we actually use that to help patients and support them where they need it?
So let's dig in there, because you've pushed, George, I would just say in a positive way, you pushed this institution to think differently about race, social determinants of health, and not only, I mean, in some ways it's clear in the practice level because you see outcomes that are so different depending on where you live, but you've pushed us to think about what does it mean to train, support, and inspire physicians. So I'd love your take on how do you feel about where you've pushed us, the university, in your leadership role, and how do you think about that internal leadership piece? Because it's a long game, right?
Very long game, yes. I would say Georgetown is very far ahead of other institutions, but still has a long way to go. In that, when I was a student, I really felt like this was the place where doors were open to conversation. And that leaders, despite, you know, maybe not having the experience with something, were still willing to listen and still willing to learn. And that's what's kept me in this institution, is that the leadership has always been receptive of thoughts about change, provocative thoughts about change, not necessarily the status quo, and really wanting to improve, not necessarily stay in the same box. So I do feel like that's the space that really I thrive in, you know, whether it's a leader who listens to me, or a leader who's willing to support me or be a sponsor to something that I'm interested in. I think the work that I've done has been supported by many people over the years, and that's how I've got where I am. So I would say the things that have moved forward really well is representation, although I would still say we have a long way to go in that space, but representation is a very different thing today than it was 26 years ago when I came to this campus. So it is very different. So I have a smile on my face as I'm walking around campus and looking to see, you know, the diversity of thought and diversity of backgrounds that are walking across the campus is very different. I think what else is different is what's represented in the faculty and the leadership. That's also changed. It's changed much slower than the student body, but it's changed. And then I would say the conversations that we're having is very different. You know, in the past, we often talked about our community and our community partners as other, and something that's not necessarily something that we could impact. Now we're much more engaged and understanding what it means to empower your community, or what it means to be co-engaged, or sharing the power dynamic, and not going into a community service opportunity and telling our community partners what we could do for them, but working together and understanding how we could serve. So I do feel like that conversation used to be very difficult 26 years ago. Now there's so much more receptiveness to that, and there's so many more people who want to partner in that space. I think I've also evolved in that maybe 25 years ago, I had a different view about volunteerism and medical tourism, in that I really felt like, okay, that's in that bucket over there, and that's not related to what I do. And so I've always felt like my role is to try to push people towards what is it to truly engage meaningfully with your community, not just to volunteer for that hour. What could you do that could impact health outcomes? But everybody's on a spectrum, and someone who starts as a volunteer or starts in that doorway of volunteerism could still be a part of that continuum of someone who ends up being the meaningful engagement place. So I really would like others to see that there's no reason to denigrate one or the other. We all have a role, and the more people in the bucket, the better. So I'm in a different place too. When I think about volunteerism, I feel like I had a very different view when I first came to the campus. Mm-hmm.
And so I guess as you open up a door of a question, I think it is important. I've been thinking a lot about too is how that journey of a volunteer from a one-time or a limited engagement to something deeper. I mean, this is a question that happens, outside the United States frequently, as well as inside. So how do you measure that? Because there is still a challenge that the short-term engagement may not be net productive, but the journey could be very much so. How do you measure that, or how do you track that? How do you know you're making progress? That people are moving, not everyone, but that the engagement of people is moving along the journey?
Well, it depends on what your goals are. If your goals are to improve health outcomes for the community you serve, then you focus on the metrics that are related to those health outcomes. If your goals are around whether your community feels empowered or they feel like they could come to you to solve their problems, to me that's a very different goal. Okay. Do you feel as though Georgetown is the space that someone would come to if they're looking for an expert to solve your problem or our community's problem? And I don't think the answer is yes to that for every community partner that we work with. And to me, when that answer becomes more of a yes and we become, we're looking for somebody from Georgetown to be a part of this project, that's a very different task, a very different look, a very different feeling from, I'm the one who's going to the partner to find out if I could work with you. So I think it's a measure of progress for us as an institution, the more collaborative we can be with our community partners, particularly in DC. And we're much more at the table with our partners. We have many more centers and institutes who are really engaged in this space of being empowering to our community partners. I think that's very different than it used to be.
I absolutely agree with that, just from my experience here over the years. But I guess, and maybe I'll do maybe like a final question before I open it to the group. I think you opened up a really interesting question in my mind about goals that are complementary but not identical, right? So if our goal as a Department of Family Medicine, as a medical faculty, or as just a academic health center, is to both be a better partner for communities to help identify and solve the problems they have, and we want to, presumably in alignment with the community, improve health outcomes, because it's both the how and the what, right? How do you manage those are two different goals. Yes. They may not play out exactly the same way. And how do you navigate that? Because that seems to me a tension that any health professional engaging in a community different than their own will have to sort.
Sure, but behind the scenes there's not really a tension. I think there's a tension externally because they seem like very different goals and they seem like they're competing against each other, and certainly I wear both hats, so I see both sides of the coin of working with a community partner and working with the health system. I do see that these things are not mutually exclusive and that there's opportunity for so much overlap in the work that we do. And so I think it behooves us to try to lift up the people who live in the middle of that Venn diagram, so to speak. There's not that many of us, but those of us who live in the middle of the overlap, who work in the health system, who are working with community partners, who see the engagement and how that results in the improvement of health outcomes. I'll give you an example of that is working with our community health workers that we work with around chronic disease. We have perinatal navigators, we have refugee navigators, we have many different community health worker training opportunities. So lifting somebody up who works in the community to serve the community in a different way, helping with care coordination, facilitating care, can really lead to someone having improved outcomes in their chronic disease, improved outcomes we have for cancer navigation. All of these are well proven in the literature, but those community health workers rarely exist in primary care spaces. and rarely exist in hospitals that take care of patients who have social needs who could benefit from that additional care coordination. So in my role in the middle of that Venn diagram is to make sure the health system invests in that space, but also in the community partnership hat, in that role, I'm encouraging my community partners to think about community health worker roles or other health system roles that potentially the community could be better represented in the health system. So to me, there's always an opportunity to work together with both of those hats. It's just making it happen and helping everybody to see the potential. Mm-hmm.
Well, that's terrific. And again, tension probably wasn't the right word, but it's not. I think it's being clear about. And so maybe I'll turn. I think this is a good. I think I'll start with Muller, if that's okay. Let's start us off. So we'll Muller and then Layla, and then we'll bring in Alan. But any final words on your navigation here that you want?
Well, I think I agree with you that it's not quite tension, but it is tension, because in a healthcare system, you know, the priorities are often about how can we sustain our dollars so that we could keep functioning. But if we don't sustain our patient population, then we're not going to be able to function. So we have to figure out how we invest in our community. So those conversations are not necessarily happening in every leadership space. So you have to make it happen. Mm-hmm.
And you see your job, that's a role that an academic leader can play to insist that that conversation happens.
Yes.
Is that?
Exactly that.
Okay. So that's a perfect way, I think, to transition to questions. But that's, it's so great to have you here. This is Muller, do you want to start us off?
Yeah, sure. Thank you, Dr. Roett. So I think as a lot of us are looking to get involved in healthcare and starting our medical education, how should we think about substantially incorporating, like thinking about health equity, advocating for health equity in our careers?
In your curriculum?
Careers.
Oh, careers, okay. Well, I think it's hard to establish that very early on, but there are examples, I think, that are really tangible at this stage. In the undergraduate and graduate stage, there are multiple organizations on this campus and centers who will have opportunities for you to have meaningful community engagement. The Center for Social Justice does some amazing work. Our Center for Health Equity works with graduate and undergraduate students. Trying to pair your experiences with centers and institutes that have structured opportunities for you to learn about the community, to engage with the community longitudinally, perhaps. There's always going to be volunteer opportunities. That's ubiquitous on a campus like this. But I encourage you to think about the centers who do this all the time and who work long-term with their community partners. They may have interests that are specific and may not necessarily align with yours at the moment, but to me, those are the spaces where you learn the most about how do we do this for the communities that need it the most.
And if you haven't connected with the Center for Social Justice, we definitely, they do have a range of, for undergrads especially. So.
Yes, definitely.
So, Layla?
Yeah, thank you so much for coming and spending your time with us this evening. I'm really curious, especially with your experience in family medicine and delivery, your perspective on how to address issues like structural racism and unequal access to healthcare, particularly in like the maternal medicine space, being somewhere in DC with such high rates of maternal death that disproportionately affect Black residents, and kind of how you see kind of working on that from the inside, from the medical space.
Sure. I suppose I'm a good person to ask that question because I'm the PI for a project that we focus specifically on this. DC Safe Baby Safe Moms is one of our MedStar programs. It's a partnership between family medicine, psychiatry, obstetrics, and gynecology, and pediatrics. And we all partner around improving health outcomes for moms and babies. And in our particular space in family medicine, we touch every aspect of maternal health and child health. And so for us, when we started this project 5 years ago now, our goal was to think about how could care coordination, how could additional resources, screening for social determinants of health, for example, facilitating interventions, linking our patients to community partners who are engaged in this space, how could that improve health outcomes? And so we started very small, but eventually the project grew tremendously so that now we have clinical partners as well as our community partners. So now we have a project with our clinical site at Fort Lincoln where I see patients, and Community of Hope that has several sites in Adams Morgan in Southeast DC and a few short-term family housing sites where we focus on perinatal navigation. And if you haven't heard of that, it's care coordination for prenatal care. And just by having a perinatal navigator who's focused on social needs, who's supporting mom, who's doing behavioral health screening, linking mom to behavioral health professionals, and making sure that mom has transportation, for example, to all of her prenatal visits, and really facilitates the journey, that we've noticed that just doing that has improved maternal mortality and severe maternal morbidity as well. And as well as improving preterm birth and low birth weight and very low birth weight. Just those things have been able to be improved by having care coordination. So what does that mean for us? That means that all the other services that we could have been providing, like having a child and adolescent psychiatrist, having a psychologist, a therapist, having a nurse navigator, someone to do home visits, all of the different things that we could be doing to support a mom, that we should be investing in those resources. So Safe Baby, Safe Moms was funded by the Clark Foundation, who's a partner for many things with MedStar and Georgetown. And Clark really pushed us to think about how do we make this work sustainable so that moms could continue to benefit from this and babies can benefit. And so we are in year 6, technically. The project ended earlier this year, and we were able to continue all of the services despite not having the funding, and understanding that our patients need the services. So we continued our services at Community of Hope. We now have maternal fetal medicine specialists helping with our process, providing free ultrasounds and free maternal fetal medicine consultations for patients. That has made a huge difference, and having the only place that's even offering that in Southeast DC, we're hoping Cedar Hill jumps into that space as well, but in Southeast, that's one of one clinic that's offering maternal fetal medicine. So there was no obstetrics to speak of in the area until Cedar Hill opened earlier this year. So understanding what your role is in thinking about devising a project. If somebody comes to you, we were really fortunate to be at the table to devise this project. But I have to say it wasn't that easy to get there. We had to really push to say, well, these are the proven strategies. If we partner with a community and we partner with moms about what they need, then their outcomes will be improved. So bringing your knowledge to the table, understanding how to change the dynamic and change the outcomes, it can really, it doesn't always result in funding to do it, but you could really direct the resources to where it's needed.
Can I just ask a follow-up on the sustainability part? Mm-hmm. So with the Clark Foundation grant ending, who stepped in to pay for the care navigation and you have to navigate to something, right? So those services, is the district government picking up the tab through Medicaid? How is MedStar involved? Maybe just a word about all the different players, because you've got Georgetown, you've got MedStar, and then you've got the community partners, whether that's Community of Hope or...
I won't bore you with all the sausage making about how you fund this work, but MedStar is paying part of it. The DC government, the DC Department of Health is paying part of it. Community of Hope is paying part of it. Our clinic is paying part of it. There are some reimbursement models that help us to more adequately bill for care coordination that are just being piloted in the MedStar system. There's some reimbursement models that CMS introduced in 2024, the Center for Medicare Medicaid Services. And so we are experimenting a little bit with how cost effectiveness models could be applied here. So I can't say that is going to be the way that we get this accomplished. We need all of the different stakeholders to be involved.
Did you imagine when you became a family physician that navigating all those organizational relationships and funding streams would be part of the job?
Probably not. No, I did envision that I would be doing this kind of work, that I would be doing the research part of it, and that I would be working with the community partners. I envisioned perhaps being in charge of the teaching portion of it, where residents and medical students and undergraduates and research assistants and all the other people that are part of our academic space, I envisioned that part of it. I think being the clinical chief in family medicine has really opened a lot of doors for me to learn about health systems management. That was my focus in my master's in public health. I did community health systems and health systems management in the International Health Department, and none of those things exist now at the School of Public Health at Hopkins. But it really gave me a foundation that I still use. Many of the things I learned, I'm still using in my grant applications, in what I do every day as a clinical chief and a chair. And so I think that space around quality improvement, quality metrics, and advancing health equity, in the beginning, I had no idea that there was such overlap between that and what it meant to eliminate health disparities. But because I was in a position to see the data, to understand the data, to do the research, then I realized that in my clinical leadership role, I'm in prime position to be the person who says, this is how we could change this. And this is what I need. These are the resources I need to change it. So I got really good at saying, I need this from you today. And I know people probably get tired of me asking, but I don't get tired of asking. Okay. So that's the point.
That's great. So Layla, so I think we'll try now if Alan's online. So if he wants to ask a question.
So this is Alan's question. First, thank you so much for coming in today. What are the current efforts behind elevating Georgetown into a position where people finally begin to see it as the place to go for seeking health specialists?
Okay, that's a good question. I do think that we're there in many ways, especially for specific specialties. I mean, Georgetown is very much known for its transplant surgery, for its neurology, for very specific needs, for its trauma surgery, for its partnerships across the MedStar system. If you ever spend time shadowing or visiting any of the wards in the hospital, you'll notice that people are coming from all over the world to be seen at Georgetown. It's a very well-known institution, and people are bringing their kids for cancer care. People are coming for the innovation in the transplant space. It is well known for this. What I would say is, and in the cancer community especially, what I would say is it's not necessarily well known for every specialty and every innovation. And to be honest, innovation in healthcare, to me, brings people to you and brings people through the doors, and certainly helps you as an institution to thrive. But it doesn't necessarily move the needle in the health disparities space, because it's a very small niche and a very small target patient population that you're trying to serve with that small innovation. It makes a complete difference in someone's life, so it's well worth the investment. So I'm not saying it's not worth the investment, but you have to balance that investment with the investment that could serve an entire community. So if we have a new drug, for example, that we know could be completely revolutionary and could cure cancer, or it could decrease your risk of having a heart attack or a stroke, then we want to invest in that drug because we want to prevent heart attack and a stroke. But when we invest in the drug, we also need to invest in the resources to make sure that this drug is going to be widely available and that it's not going to cost $5,000 for the community that needs this drug. So to me, you have to balance how you invest. So I say all that to say Georgetown is well known in this space already. For it to be known as the expert in eliminating disparities, I think that's where we need to move ourselves forward and stand up to be noticed in the work that we're doing. Mm-hmm.
So I'll ask a follow-up. So if that's our goal, what are the next things we need to do? I mean, I'm not sure anyone does that perfectly, right. But what if we want to become known as one of the places that's tackling this? What do we need to do next?
I think we're extremely humble about the work that we do, especially the work that we do in the DC community. I think we're much more likely to elevate our work on the global stage and much more likely to elevate anything that's, in the news at the moment. So what's in the news at the moment. So vaccine hesitancy, all of the work that we're doing in the public health arena and public policy, it makes sense because you need to be able to match what the public discourse is with the work that we're doing. I do think that sometimes takes away from the underlying goal of what we need to be able to provide in order for the community to have improved health outcomes. We can lose sight of that sometimes because we're trying to move with the times. It's a little bit of a moving goalpost, but every institution has to wrestle with that. How do you move with the times and make sure that you're focused on the underlying fundamentals of how you serve a community? And I'm not so sure that we have always had a group of academia, a group in academia who's that focused on that fundamental portion. So we have a great group of people now who are very focused in this space. People in the School of Health, in the School of Nursing, in McCourt, in the main campus, in every institution, in the law center. In every institution in Georgetown, we can find representatives who are really focused in this space. I would say we don't have a forum for them all to be recognized or to really speak up about their work. We do a lot of that in the Center for Health Equity, just talking about what we do and sharing what we do so that we could collaborate further and be more synergistic and be more, be multipliers instead of duplicators is what we like to say. We like to elevate the work so that it has much more of an impact rather than duplicating work that affects a very small portion of the population. So if I have a really effective study that affects 5 people, then I'm not going to be able to have an impact on my community. So having a multiplier effect and being able to expand that study and collaborate with multiple institutions is much more impactful. So bringing people together, having a forum to talk about our work, lifting each other up, making sure that the institution knows the value of this work and that we have enough support to do the work that we need to do, that potentially could allow Georgetown to be at the forefront when someone's thinking about, I need an expert in this, then I need to look at Georgetown. Mm-hmm.
It's a good idea. So now I think we can open it up to the group. Any questions? Oh, there we go. All right. Why don't we start left and we'll move our way around here. So, please.
So I was just wondering, you said earlier that innovation is what gets people through the door, and so I was kind of curious about your thoughts on AI in the primary care setting. With like ambient listening and telehealth kind of on the merge, in kind of relation to addressing the iron triangle with quality access. And cost, all while trying to also answer the question of equity.
Yes. We were just talking about this today, actually, because we're submitting a grant in this AI space. And so there's lots of potential with using AI in your scribe technology, for example, with ambient listening is what she was referring to. And so everybody's familiar with scribes who document notes in a doctor's office. So most of the AI tools that we have that we use for scribing are typically just listening to the visit and really interpreting the visit and documenting it in a specific way. So it's much different from transcription or dictation in that it's not documenting, there's not a transcript, it's not documenting every word, but it's interpreting what you're saying and documenting it in a useful way. So what we use an AI tool called Suki in the MedStar system, and it does this ambient listening in our primary care practices. Very effective. I don't think it's made my life any simpler in that it's not faster for me because I never had an issue with documenting quickly. But what it does really effectively is it documents social determinants of health. And I don't think people recognize this effectively yet. So we were just talking about this today. How could we leverage an AI scribe tool to more effectively document social determinants of health? Because physicians, we do a really bad job of this. You could spend the entire visit talking about homelessness or being evicted and it doesn't get documented because it was a conversation you had with the patient about something that's happening in their lives. But 90% of the clinicians will not put that in the chart, or they might remember to say potentially homeless or something, but they won't document most of what's being said. There might be something very small about it. And so because we don't document, we're not coding, we're not billing, we're not really putting it in the places that I could follow up with this particular patient about this case. But in ambient listening technology, you could theoretically mine the electronic health record for more mention of social determinants and set yourself up for a much more successful care coordination plan if you knew the volume that you were dealing with. But it's a problem that we have currently in ambulatory settings, not just in primary care, that we don't document things well enough. So just looking at data now and just pulling reports about social determinants today, you would think that there's probably a 1 to 5% issue of social determinants amongst your patients. That's never true. And most of the time it's more like 20 to 30%, but your patient, maybe they weren't comfortable talking about it, or maybe they did and you didn't write it down, or maybe it was told to a nurse and it wasn't told to the physician, so nothing was done about it, or maybe there were no resources to do anything about it, so the practice didn't address it. So there's a lot of different ways I think you could look at it, and you could leverage it to advance health equity. Mm-hmm.
I'm just sort of moving along here. Who else? I saw a couple more hands. Sapporo?
And so seeing your life work and how you've successfully led discussions surrounding community service and provocative ideas around addressing the needs of underrepresented and underserved communities in medical spaces, how has your ambition toward eliminating health disparities or health inequities grown over time? What kind of, and the second part to my question, even though I can repeat it after, what kind of leadership styles have you had to adapt to be where you are now?
Okay, two very different questions. So the first question, so eliminating disparities is not necessarily something that you could just decide that this is what you're going to do and that you could apply your skills and your time to doing it. I think it took a long time for me to see that I could be engaged in this space clinically as well as in my community service and community partnerships. And as I was saying earlier, it really took a deep dive into the quality of care for me to understand that the healthcare disparities and the healthcare disparities that we were trying to address with our community partnerships, we would never be able to address them unless we partnered with the clinical settings too. And to be honest, based on the literature, the more primary care clinicians there are in a community, the more likely that health disparities can be eliminated, because there's much more prevention, there's much more early detection, you get more colon cancer screening, more breast cancer screening, more screening for diabetes. So it makes sense that if there's more primary care, that there's less disparities. The issue is it's just never that simple, and there's not enough primary care clinicians to address all of the needs of everybody. We have a primary care shortage. There's a shortage of 40,000 family medicine in particular, but primary care across the board, there's a shortage. There's health professional shortage areas. DC is a very large health professional shortage area. Why would that be? We have so many doctors in this very small space in DC, but they're in very, very limited subspecialties. So if I get, I'm not picking on any particular specialty, but if I get 10 more plastic surgeons, does that help me necessarily to address the disparity in breast cancer mortality for the city? It could help me if a breast surgeon came to a space where there were no breast surgeons. It could help me if a plastic surgeon came to the space to help with a specific need if there were no plastic surgeons. But it's difficult to encourage students around what specialty to choose based on that conversation. So what I do instead is I just talk about the community. I talk about how to eliminate disparities based on your clinical roles and your community-based roles. And I do my best to try to paint the picture. And it's up to you to decide what specialty you want to do. We need everybody in every specialty, so I'm not going to discourage anyone. But I really want, no matter what direction you choose, that you recognize what your role could be in your community for eliminating disparities. And then your second question, what was the second question?
My second question was, what kind of leadership styles have you had to adapt to be where you are now?
Sure. I mean, I've always been a very inclusive leader. I like to listen more than I like to talk. I do not like public speaking, typically, and so I usually say no to public speaking. But I'm learning. This is something new I need to do. You know,
Appreciate your
yes.
coming. I knew it was going to. We have to persuade you.
Yes, and the reason why is because I'm an introvert. I really, I get very nervous in public speaking environments. And so I've learned over the years how to adapt. I pretend I'm Oprah or something, and it usually helps me, that I'm just focused on not being myself, like Beyonce does Sasha Fierce or something. So I'm just in a different headspace. So it helps me. But as a leader, you also have to recognize, not just your shortcomings and your weaknesses, but your strengths. And what I've learned is over the years that my storytelling about my experiences with my patients and my experiences in the clinical setting, my experiences with community partners, that I have a talent in doing that, in writing it for grants, in telling a story, in ensuring that the leaders that I work with understand the impact of the decisions that we're making. And so I do have to recognize that inclusive leadership can only take me so far, and that I have to be willing to step up and use the skills that I have in the rooms that it matters. And so as an introvert, that is very painful to do, So over the years, I've really had to work hard on that and step outside my comfort zone quite a bit by saying yes to things like this, but also going to national conferences, doing national presentations, presenting the work that I'm doing on different stages so that I feel comfortable. And you get a lot of support in national, conferences, especially in your specialty. So understanding that the community is just like you, everybody's just like you. It's not like, they're expecting you to, to be Oprah. They're really just wanting to do the work and they're wanting to improve. So I think that's helped me as a leader to grow and understand that everybody's got shortcomings and everybody's got something. There's lots of introverts in this space too, and it's okay to be that. So I can be inclusive. I can also put my foot down. And I also understand that I need to be the sponsor and need to be the person that lifts other people up. Yeah.
Please.
We've talked about how you've helped champion a lot of change here at Georgetown. When advocating for these structural changes to address health inequities or representation, what approaches have you found to have been most successful for those of us who want to help drive this change later in our careers?
Great. I think one of the most powerful ways to move the needle in an institution like Georgetown is for leaders to hear from students. I mean, I feel like that's a lesson that I've learned over these last 26 years, is change is much more likely to happen if students ask for it. I totally could be asking for the same thing like for 15 years. It's not going to happen unless students say that it's important to them. And I feel like we were very late to the game with this. So we were teaching students about disparities for the last 25 years. The LCME, the accreditation body for medical schools, asked that we include public health, that we include disparities, that we talk about this. And so we started teaching students about race in medicine and health disparities and eliminating health disparities and all of the different lessons. And then we realized they were then going out into clinical spaces and working with doctors or other health professionals who hadn't had this training. What does that mean? There's going to be some clashes in that environment. And so we said, we're not really setting these students up for success, because sometimes if they ask for something, it changes. Sometimes it doesn't. And it could be frustrating. So we decided to have a multi-pronged approach. So lift students up, make sure that they've got support in what change they want to see. Listen to students, because we don't always know what the right thing is or what the next step is, because you're going to be the next generation of leaders, and I'm going to be working for one of you one of these days. So lifting you up, but also making sure that we're training all the people who are going to be responsible for training you. The faculty, the residents, everybody who you're going to encounter along the way. We need to be responsible for them too. So doing more faculty development and making more training available, pulling all the faculty along to learn about what meaningful community engagement is and advancing health equity. So that is a different approach that we've had these last probably 5 years or so that's really made a huge difference, so that students, once you get into these environments, that you've got more people that are modeling this work. Yeah.
Yeah. You mentioned before, like, you care about medical students trying to pick their specialty, and you can't really directly encourage medical students to go into primary care, to go into a specific specialty. So, and I know in your work you've done a lot of stuff with, like, understanding medical school recruitment strategies to increase the number of students interested in primary care. And I was wondering, are there other systematic ways to increase that number of primary and family medicine doctors outside of just things related to medical school?
Yes, I mean, I think this is a debate that's probably going to be going on for another, couple of decades. But in what we've published so far in this space, we know that if you change your policies around recruiting for primary care, that you get more people who want to do primary care. That's a very basic thing that you could do. So there are quite a few medical schools around the country who recruit for primary care, and that's their goal, it's their mission. Often you'll see more DO schools do this than MD schools, but there are MD schools who recruit for primary care too. And then some medical schools are state schools or are very entrenched in their community and the outcomes in the community, and so they recruit based on wanting people to stay in the community and serve. So if you're recruiting based on wanting people to stay in the community, then you really need to recruit based on who could improve outcomes. So sometimes that means more primary care, but sometimes that could mean other specialties too, based on what the needs are in the community. So I would say I do actually try to encourage people to do primary care. I don't denigrate other specialties, but I do a lot of presentations. We just did one today in our family medicine open house about what is family medicine, what is primary care, what's the benefit of primary care. And then we try to have more shadowing experiences for students too. And across the country, that has been shown. If you have earlier experiences, mostly in primary care settings, you get to do more. You get to see more. You get to see more pathology. You don't necessarily get to do that if you're in nobody's going to let you do anything in an OR if you're not a medical student. So in your shadowing experiences, sometimes doing more shadowing in primary care settings gives you more clinical experience, but sometimes it also plants the seed. This is what I want to do. So, we haven't been very organized about that over the years, and many other specialties kind of jumped into this very early. There's fellowships in dermatology. You could go do a gap year in an ophthalmology office. You could be an MA in any specialty, but I don't think necessarily that every person who's going into medical school is thinking about being an MA during their gap year. But it is a really useful preparation tool. I sit on the admissions committee for the School of Medicine, and oftentimes we are considering, the holistic approach and the holistic view of you as an applicant. And you'd be surprised that majority of our students that we matriculate have gap years. They've been doing something else. It could be research, it could be clinical work, it could be scribing, but they have other experiences. It could be a master's degree, it could be many things. So I would say my goal in the pathway pipeline programs that we're engaged in for high school students, for community college students, is to just give them the exposure to primary care so that they know it exists, they know the value, have some fun doing it, show them some of the aspects of how we take care of ourselves and why we're happy doing our jobs. And hopefully, 10 years from now, some of those students will be choosing these primary care careers too.
I think at one study you worked on, it's striking to me just prioritizing.
Yeah.
If the medical school just prioritizes primary care, it makes a difference, which gives you a sense of what was not happening. So I was shifting to this side of the room. Other folks? Did I miss? Did I miss somebody? I'm sorry. Oh, please. Oh yeah, please. I'm sorry, I missed you.
No worries. My question is sort of related to the shortage of physicians in general, but because there's shortage of physicians, there's obviously a shortage of primary care providers. So if I'm not mistaken, back in the 90s, the AMA sort of lobbied Congress to cap residency slots
Mhm.
at medical schools.
Mhm.
So I was just wondering how sort of that has sort of carried over into to modern day.
Mhm.
And also, there's obviously a lack of incentive to almost be a primary care provider. So what do you think is sort of which factors
Sure.
pushing more?
Well, that's a loaded question in many ways, but yes, it is true that the cap on training slots is a very political space that we can't solve in this class, but the increase of slots comes up in every administration, in every budget, and it has been very positively received by every Congress. So that tells you that every person who's representing a state is recognizing the need for more physicians and that there's not enough. I think there's also recognition that there's tremendous burnout across multiple specialties, and that often is because there's not enough people doing the work. So, no matter what specialty you think of, I could tell you which ones have the most burnout, but to be honest, that burnout is going to be consistent and ubiquitous because there's not enough physicians in multiple specialties. So I would say that there's political will in this space to solve the issue. It's just it costs a lot of money to train physicians. So it's not popular because it costs too much. Budgets never expand in order to add slots for training physicians.
Right.
So that's not something that we typically rely on for that. So there are many what we call graduate medical education naive hospitals who've never had trainees before. There's opportunity there to expand training without having an additional budget from the Center for Medicare and Medicaid Services. That's another sausage making thing that I don't think you need to be too worried about. But there's ways for hospitals to add slots without having to have a new budget and increase slots. The other thing is that every specialty has a lobby. So everybody has a different reason why they want more slots. So I'm not picking on plastic surgery, I promise you, because I have plenty of wonderful plastic surgeon colleagues that I love sending my patients to. But if I, as a plastic surgeon, decided that I just want more plastic surgery and that we have a lobby for plastic surgery, I need to have a specific reasoning behind that about which communities, how can I do this, in which states have a shortage. And to be honest, every specialty doesn't have that approach of understanding where the needs are. Family medicine is not, we don't toot our own horn enough, I think, to talk about all 50 states needing more family docs, because you could show the health professional shortage areas in every state and the states that have more primary care and have more family medicine, and you could see where the outcomes are better. So I think in terms of the slots, we haven't quite connected those two conversations in a way that has resulted in more family medicine. There is a teaching health center opportunity. I'm not sure if you've heard of that before. That's another way to fund residency slots. And teaching health centers are typically partnerships with community health centers. They typically fund primary care residency training. They're mostly in the outpatient setting. They still have some inpatient training, but mostly outpatient setting, so that it's decentralizing trainees so that you're not only affiliated with a hospital. We have a teaching health center grant with Community of Hope, a community health center in DC. So that could be another way to fund other slots, but again, teaching health centers are funded by the government too. They're HRSA funded. So our HRSA funding is caught up in the continuing resolution, so we don't know if we're gonna get it. So it can be very political depending on the discourse at the time. Mm-hmm.
It's a tricky question. We'll have a number of people when Christy Martin comes, we can talk a little bit about CMS, as well as when Lily Ryan, she can tell you about the pain of dividing up slots on the Hill, which is no fun. So I want to get this side of the room, so why don't we start down here, please?
Yeah, I have sort of two questions, but they're related to the same issue, both on the shortage. I know some doctor offices started using Zoom or other virtual meetings so their doctors can see more patients, but at the cost of making the visit less personal. Do you think there's a high value in doctor to patient physical, like in-person face-to-face contact, or is it okay to let the doctor be able to switch more quickly between two patients, but not develop as strong a connection with them. And the second one, you mentioned there's not a lot of incentives for people to do primary care, and there's a shortage of doctors. I'm also thinking that at least for the emergency services, they have like 4 different levels. So a lot of people enter in as an EMR. The highest would be a paramedic, but then there's 2 other sub-levels for people who want to go a bit higher but don't want to dedicate as much time and money to education. Would something like that be possible in the primary care sector?
That's a really good question. I've already forgot your first question. What's the first question again?
Relating to Zoom.
The Zoom, okay, so telehealth. So telehealth, I think it has its benefits. I mean, there's sometimes you can't get to the office. I mean, you yourselves know the benefit of being able to see your doctor by telehealth rather than having to go into the office. So I definitely have used that with my doctor for my own care, and I've used it for my dad's care. I take care of my dad. And so from a convenience perspective, it's still very beneficial. I would say it's probably not the best way to meet your patient for the first time, but it has its place for emergency needs, so urgent carers use it too, so there's no relationship there. So I think there's a place for telehealth. It definitely has a good convenience marker, and certainly can help you to reach your patient where they are. There's a digital divide though, so there's so many patients who have no access to a smartphone. And I learned during the pandemic that so many of my patients over the age of 65 who were sending me random emails in the middle of the night did not have a smartphone. And the phones that they had, not able to do telehealth, or they didn't have a tablet or computer or all the other things that you could do telehealth on. So I do think there has to be some investment in that space too, so that there could be equitable access across populations, because everybody doesn't have that access. Your second question, I'm so sorry, I'm so bad at this. What is your second question?
Would it be possible to, instead of just going fully a primary care doctor, since it looks like there's a
Do
lot of
different levels.
Different levels.
So I mean, I think that's probably a good question too, that you could spend a whole session on.
Yeah, right.
Mid-levels and advanced practice providers, and so this is what we talk about, like physician assistants, nurse practitioners. Advanced practice providers is the category that we talk about. Unfortunately, are not choosing primary care as their careers. And so it's not a solution today because everybody's not choosing it. So we have the same issue with advanced practice providers, is that they're choosing the specialties, the other specialties, and the subspecialties are the inpatient side of things, but not choosing primary care careers. I think it could be a potential space that's helpful, and many of us work with PAs, NPs, DNPs, multiple advanced practice providers, and have a really good relationship. I trained alongside multiple nurse practitioners. PAs work in our system pretty commonly across the MedStar system, but working in the primary care space is not happening as much. So more primary care, more health systems that want to expand their primary care are investing in advanced practice provider training to try to achieve that different level of care. And I would say it's not the same training. So what we used to call mid-level, but advanced practice provider does really well is keep up with the continuity of care with a patient and provide that bridge. What a physician does that distinguishes ourselves as a physician is we do the comprehensiveness of care. So, so that distinguishes the two roles. So we're typically not competing for the same patients or the same positions, which I think is a myth that has been, perpetuated, that people think that somehow advanced practice providers can serve in the same space as a primary care doc. So why do we need any primary care docs? But we're not even there. We need so much more help in seeing patients. So everybody is welcome at the table. Mm-hmm.
And it is a funding compensation. I mean, at the end of the day, it's the payment. There are benefits from the payer's standpoint to pay less.
For an advanced practice provider, that's true.
And from the provider's perspective, there's an advantage to being a specialist where you get to pay. So it's.
Well, that brings up a good point. So I talk to students about this all the time, that 90% of doctors do not make their choice of their careers based on what they're going to get paid. We make our choices based on what we want to do, who we want to serve, the patients we want to take care of, what makes us excited about medicine. We know that we're all going to be getting paid very well. I mean, so it's a matter of, are you going to be getting paid close to, you know, $500,000? Or are you going to get paid $300,000? Those two things are not that different. And so I don't think, you know, I think based on the literature, it's always borne out that doctors who choose family medicine or doctors who choose other specialties are not choosing them because of the money. No. So that may be true in some other spaces, but not with medicine. Yeah.
Oh, please.
As a physician in family medicine, there seems to be a lot of obstacles to face, such as limited time with patients for proper education and barriers that hinder access to medication, such as prior authorization. These obstacles can harm health literacy and patient outcomes, so what can we do to alleviate these barriers and health disparities?
So health literacy is a bucket in and of itself, you know, in terms of addressing it. As a physician, you've got limited options in terms of addressing health literacy. And there's a limited amount of health education that you could provide in a doctor's visit or in a doctor's office. What you can do is adapt your services to address universally limited health literacy. So that means adapting, you know, how you communicate, the resources that you have, the style of, you know, the office. So is it an office where somebody has to come in and use a tablet, or is it an office where somebody's available to help someone? You know, I had a patient for many years who was always very upset whenever she came into the office, and was always in an argument at the front desk whenever I'm like, oh, she's here. And whenever I got her back to the room, she was totally fine, like completely, you know, pleasant, very nice. We never had any issues in the room. And then I knew her for maybe like 2 or 3 years. This is maybe 15 years ago that we finally had this conversation. I realized that she couldn't read. And that never came up in any of our conversations. She was really very uncomfortable when somebody gave her a form to fill out or a tablet that she needed to check in for the visit. And so she got really upset that there was no accommodation for her and didn't quite know how to articulate that, but just really got frustrated. Every time she came to the health system, she felt like she wasn't being heard or seen and that nobody was really understanding her needs. And once we knew that, I mean, that completely changed, you know, how we were able to address her needs from the front desk to the nursing to the doctor's visit. So I do think there are ways that you can accommodate for patients based on universally addressing limited health literacy, because you can estimate certainly in your patient population what the limited health literacy rate might be, but you don't really want to get into a place of assessing people's literacy in order to decide what services to give them. So, and most practices will not do that. I know there's another part of your question that I probably missed.
I mentioned the prior authorization.
That's an
issue between the insurance companies and
Sure.
the physician. It just seems to bring a lot of frustration to everybody.
Sure.
So.
I mean, there's some angst in that space. As a physician, this is not something that you typically address, to be honest. As a primary care doc, I've been in my practice for 22 years, never had to do prior authorization for somebody for anything, you know, because we have staff who do this for us. But if you were a solo doc and you're the only person in your practice, you could be doing that. Insurance companies have made it a little harder to do some things. So I know that if I order an MRI for someone, that their insurance company probably is going to require prior authorization to get that MRI. But I know that that's true. So I will let the patient know this is probably going to take another day or so before it gets authorized. But we have a referral specialist who's going to do this prior authorization for you. So I think you adapt your services based on that. When I was a resident and a medical student, the very office that I work in now did not have those services. And so it was, I don't know, I feel like the practice manager used to do it. Somebody else would do it. And, you know, it really was something that would slip through the cracks, that some docs would get so frustrated, like, I'm not ordering this MRI because I don't want any delays. So, and then unfortunately, there would be situations where a patient might go to the emergency room hoping to get that MRI, which is not going to happen in the MRI. An MRI is not going to happen unless there's an emergency situation. So I would say there's some myths around prior authorization and what it could limit. Prior authorization might stop you from being admitted for a voluntary psychiatric admission. It might stop you from getting radiology approved. It might stop you from getting an elective surgery. But most things that you need, it is just a formality, and you will get it, and it will be approved. It is not that common, actually, for things to be denied unless it's not medically necessary. So I do think that some insurance companies take it a little bit farther than they should in terms of putting the barriers in the way and putting prior authorizations as a requirement, when really, why are you going to put that there if you're going to authorize everything? Then there shouldn't be a prior authorization if everything is approved. So, that should tell us that that's not necessary. So I'm hopeful that those barriers go away so there's no delays, but it doesn't necessarily change what you could offer a patient. Yeah. Mm-hmm.
I'm looking at Ella.
Okay, yeah. Yeah, hi. I'm really interested in your thoughts on kind of the intersection of individualized care for patient mental health and that intersection with just other facets of medicine. I know there's been a lot of literature in the area, but there's of course still a really big stigma surrounding care of the whole person, integrating that comprehensive mental health care. For example, I know some of us work in emergency medicine here, and in emergency medicine I've seen lots of mental health crises just being commonly disrespected or treated just a lot differently than other traumatic or medical emergencies. So I guess my question for you is, in such a personalized and comprehensive specialty like family medicine, where do you think that specialty of family medicine succeeds in that intersection between balancing the care for mental health and other physical ailments, the whole body portion, and what are some ways that the specialty could grow in that area?
Great question. Family medicine has a requirement to teach and train integrated behavioral health. And so even when I was a resident, so that was a while ago, we had to learn about taking care of anxiety, depression, really a broad spectrum of mental illness, including severe mental illnesses in the inpatient setting. And then the goal of that is so that you could recognize mental illness, that you could diagnose, you could treat, you could understand when you need to be co-managing, when you need to refer or consult with a psychiatrist, or when somebody needs to go to the emergency room and be admitted to a hospital. You have to know this in multiple specialties. In family medicine, they took it a step further, not just being able to recognize, but being able to treat a patient on your own. And so integrated behavioral health is a requirement for all family medicine training. That's expanded since I was a resident. So now our residents are learning alongside psychiatrists and child and adolescent psychiatrists and psychologists. And we have a psychologist and an LPC, licensed professional counselor, working in our practice, who do a lot of training for our residents on how to counsel. So not just the diagnose or prescription, but how do I counsel my patients? How do I engage in therapy? How do I become a partner with my patient in their mental health journey? I always felt, and I had the early interest in psychiatry, I always felt like family medicine was the place that I got to learn about my patients' lives. And I felt like it was that perfect marriage of that psychiatry interest that I had with getting to know everything about a patient and taking care of all aspects of their care. So I still see it as something that's a benefit of family medicine. What we don't do is, I don't think we necessarily integrate the severe mental illness into our practices. There's still a tendency to co-locate psychiatry for severe mental illness. And that doesn't necessarily work unless you can train more psychiatrists to work in that space. There's something called collaborative care, or the collaborative care model that psychiatrists do with other doctors. So it doesn't have to be family medicine. It could be internal medicine. It could be other specialties where a psychiatrist could be taking care of a patient, but they're seeing their primary care doc or another doc, and then a care manager, social worker, somebody else is doing the bridge care in between. That model has got a lot of traction. It's not as popular, I would say, in family medicine because we're still not really working together. We're just kind of bridging services and making sure the patient gets their prescriptions on time. So I don't think that's a perfect model, but it's much better than let me just write a referral and go find a psychiatrist. And oftentimes your patient is not going because they need to have the patient-centered approach. Here right now, I need somebody to help me. So I just diagnosed somebody with bipolar disorder maybe a month or two ago who seems to be doing really well. And I think 25 years ago, if I was in that position, that I wouldn't have been comfortable prescribing the medication needed, deciding on a plan of action, talking to a therapist about, really this patient is really appropriate for your therapy model, and helping the patient to see the benefits of seeing psychiatry. I think it's the training that really helps to make you feel comfortable having that conversation with the patient, and for the patient to have the trust in you that perhaps, this is the right place for me, that I could get all of my care. So we're not in a perfect space, but we're moving forward. So that's all we can ask. Mm-hmm. Yeah. Mm-hmm.
Questions on this?
Mm-hmm.
Yeah, I really like how you bring everything back to the community and community healthcare. So I'm wondering what have been the most effective community-based healthcare programs in reducing health inequities.
Mm-hmm. Yeah, I think it depends on the focus area that the community partnership or community-based organization is in. So the Safe Baby, Safe Moms project that I talked about earlier, there's several community-based organizations that are focused on that maternal health space. So if you've not heard of Mama Toto Village in DC, they do a lot of work, typically around doulas, midwifery, providing support, care coordination, mom-baby classes, everything imaginable that you might need. And they partner with MedStar Health as well in the Safe Baby, Safe Mom space. So different organizations focus on different areas. The Ralph Lauren Center with Dr. Lucy, I don't know if she's invited to the course, but she should be at some point.
I've tried,
Okay.
but she's promised me she'll come.
Okay, I hope she does. So Dr. Lucille Adams Campbell is somebody who does some great work in the cancer disparity space, particularly breast cancer, and community-based organizations that partner with her, and then her center, I think that her current center is in Southeast DC, really does a great job in bringing the services to the community. So mammography, breast cancer screening, having navigation, linking patients to care if they happen to have a diagnosis. So understanding that the landscape of community-based organizations is broad. Everybody has a very different focus. You don't have to necessarily have a one-stop shop. That's going to be very unusual in a CBO. I mean, they're doing what they do really well, and they exist because they do a really good job at it. So think about, what is it that they do that's so successful, and how could I support their work potentially? Not necessarily what could they do for me, but what could I do for you? And to me, if you come with that approach, oftentimes you'll find other ways that you could elevate their work in a way that could reach more patients. I could just simply send some of my patients to you, or can you come talk to some of our organizations or our healthcare system about the work you do, so that they understand the value of partnering with a community partner. So I think the CBOs all do different things, and we have about 30 community partners that we work with on a regular basis. And it's a very wide gamut. It could be an after-school program, it could be a church, it could be a barbershop. So understanding that everybody comes to the table with a different skill set and a different target population that they're working with, and different expertise, and trying to lean into that expertise and learn from that. Hopefully that answers your question.
I think we're getting close here. There's any other, probably two, we got one. One short question. How about?
Kind of going back to the mental health question, earlier you were talking about how, going from pregnancy to childbirth can be an emotional journey, and how you playing the role of a catalyst in that process can be rewarding. But I can also imagine how being that deeply involved in patients' lives can be an emotional burden to you, and I know that's something a lot of people going into family medicine sort of fear. So my question is, do you have any advice for prospective students in family medicine on dealing with that stress that comes with the job?
Sure, that's a great question. I think that's a good one.
It's a good final question,
Yes.
exactly.
I think you have to recognize, especially during the path to medicine, that every specialty is going to be filled with a tremendous amount of stressors and with devastating experiences. You know, you're seeing people at their most vulnerable moment. You're going to be part of a conversation about death. You're going to be in really difficult situations in this career, no matter what specialty you choose. In family medicine, I feel like we do a good job of training our doctors on recognizing your work-life balance and prioritizing well-being so that you're not feeling that burden. I've never felt like I was even close to being burnt out because, you know, to be honest, that prioritization of well-being has always been there for me. I'm a working out person. I listen to a lot of weird British murder mysteries. I spend time with my friends. I spend time with my family. You know, I have my own journey of figuring out what works for me, for my own wellness. And so that becomes something that I pass on to all the trainees that I work with. This is just what you got to do. You got to think of what works for you. So in the medical school, we do a couple of different things to try to train medical students to think of what am I going to do to maintain my wellness journey in this stressful path. Because that burnout is real. It could hit you before you even finish medical school. So, so mind-body medicine is something that we use a lot with medical students, but we also do not hesitate to recommend therapy, counseling, all of the different things on the menu that wellness can bring. We really try to figure out, well, what is it that could work for you, and how could I support you to do that, to carve out the time to make it happen. Yeah, you're not going to be able to avoid the devastating stories that happen in your patients' lives. So for me, I'm okay with crying with my patients. I cry at commercials too. So I'm a crier. So I'm okay with that. You know, I don't take it home with me though. So I'm there, I'm present in the situation. That's all you can ask. I'm there for my patients. They're there for me too. They cried with me when I lost my mom. So I would say, you know, you're not gonna be able to avoid that in any specialty. So you're gonna feel your feelings, and that's totally okay. But you have to figure out how to balance and find your wellness. Yeah.
Well, I guess I would ask everybody to join me in a round of applause for Dr. Roett.